Hello. Well, ladies and gentlemen, I wish to thank Professor Branko first to invite me and deliver this talk during this August gathering. Very good morning, ladies and gentlemen. Warm greetings from India. Let me first of all thank Professor Branko for inviting me to join this international meet and deliver the talk on long gap, Tracheo-Oesophageal Fistula and esophageal atresia. I very much regret not to be physically present here during this gathering. However, I really appreciate Professor Kiamba, who has taken over the responsibility and delivered the talk on my behalf. Tracheo-Oesophageal Fistula and esophageal atresia still remains the epitome and reflects the eminence and experience of a particular pediatric surgeon who has attained excellence in the field. Our institute in New Delhi is a premier tertiary care level institute with the neonatal surgical ICU established somewhere in 1980. Since then, the results for the neonatal surgical procedures improved remarkably, and TEF and esophageal atresia is one of them. During the past 32 years, we have seen more than 1,400 cases of TEF. It is surprising that more than 4,000 cases of TEF are born each year in India, but because of the limited facilities available, not more than 20% find the ways to the institutions where the surgery could be performed. Late presentation is another factor that also contributes to morbidity and mortality. The other factors which are responsible for very high mortality and morbidity in India include the poor weight, prematurity, chest infection, and many associated problems, especially the complex ones, and which are not uncommon in such cases. Next slide. This slide shows the various types of the anomalous situations seen in wide gap or long gap esophageal atresia. As you know, the one most common is the one where there is a upper pouch blind and the lower pouch communicates with the trachea. Normally it is amenable to primary anastomosis. However, there could be a situation when the anastomosis is possible but remains under tension, or sometimes the gap is wide than more than 2 or even 3 vertebrae, and then primary anastomosis is not feasible despite adopting various measures. Another such situation arises in a pure esophageal atresia and also termed as atresia with long gap, where the gap is more than 3 vertebrae and both pouches remain without the fistulae. Upper pouch is quite high and lower pouch is quite low. Let us concentrate on these two situations, how to manage. Next slide. The TEF primary repair is the most common procedure that is done surgically. However, recently thoracoscopic procedures can also be performed, and the largest experience has been from USA. Hello. जी हाँ जी Sorry for the interruption. So whenever there is a primary anastomosis performed for the tracheoesophageal fistula, few precautions are adapted. Though there are various ways how to repair tracheoesophageal fistula, but most common approaches include that we go through the fourth intercostal space, and it's only very rarely that a rib resection is required, and this is usually the situation for redo cases. Extrapleural is the standard approach and adopted in more than 90% cases. It's only extremely unusual, or maybe in a premature baby with low weight, where intrapleural approach can also be adapted, and the results are no more different. The upper pouch mobilization is required in almost all cases, and myotomy has been one procedure that could be used, but not many surgeons are experienced with it, and not very frequently it is adapted, because the anastomosis can be performed without myotomy even, and of course myotomy has its own disadvantages. It's contrary to the belief the lower pouch can also be mobilized to great extent, though the lower segment of the esophagus has a segmental blood supply coming directly from the aorta, but still few branches can be sacrificed and the end of the lower pouch still remains viable. A single layer anastomosis is good enough. However, fine suture is used and all are interrupted. Mucosa must be included to give strength to the anastomosis. A trans-anastomotic feeding tube is usually inserted, and we prefer it because the feeding can be resumed after 24 hours or 48 hours gap, and this avoids the need for total parental nutrition. We prefer to give expressed breast milk from the mother to the baby after 48 hours. We still continue putting the chest tube to detect any leak in such cases. Repair can also be made under tension, and in such situations we adopt a policy to paralyze the patient in the postoperative period with an elective ventilation, and this tides over the initial period for 3-4 days till the anastomosis gains strength and a leak-free anastomosis can be expected. Next slide. This shows our experience in more than 350 cases during 8 years in late 90s. The outcome was that mortality after major leak was very high to the extent of 74% cases. Mortality after primary diversion was also quite high in 45% cases, and there was a poor outcome in case the redo of the anastomosis was performed in our cases, though the number was small, but it was as 9 out of 12, means 75%. Another interesting finding from our series during that time was that whenever we performed diversion with esophagostomy in the neck and a gastrostomy in the abdomen, these children did not return for follow-up, and 72% of them were lost. It means only 28% came for definitive procedure for esophageal replacement. It means almost 3/4 of these either died at home or developed other complications and did not return to us. Next slide. Hence, this remains how to repair the tracheoesophageal fistula, especially those which are with a long gap, and gap could be as wide as 2 to 7 vertebrae. The management always remains controversial, and it depends on the ingenuity of the surgeon who is experienced to adopt a particular procedure. It may be emphasized once again that every attempt should be made while making a primary anastomosis or attempting the repair of the esophageal fistula that a native esophagus always should be preserved as far as it is possible. Next slide. This slide shows that Tracheo-Oesophageal fistula, still there are two common methods. One is primary repair by open surgery, and another one is the endoscopic repair, the thoracoscopic surgery. If there is a wide gap and there is a difficult situation, then the anastomosis can be done under tension and with or without paralysis and a ventilated support in the post-operative period for a varying period for 2 to 5 days. And during this time, the healing of the anastomosis takes place and there may not be a leak in such a situation. Myotomy can also be performed, but it is not a very popular procedure, and the post-myotomy problems like diverticuli formation and dysmotility of the esophagus are also well known. We don't have much experience with this procedure. In case of difficult situations and a wide upper pouch, a flap can also be designed to bridge the gap and make a tube, but this is also not a procedure that is favored because it involves construction of a esophagus with a long suture line, and it has a tendency to leak and create problem in the post-operative period. Thus, in our view, if feasible, a primary anastomosis is always preferred rather than either to use myotomy or to use any flap techniques. Next slide. What are the various options other than myotomy and flap technique to bridge the gap in case there is a wide gap, tracheo-esophageal fistula? Kimura's technique is one that has been used recently, and it involves serial lengthening of the esophagus. The upper pouch of the esophagus is brought onto the chest wall, and then it is lengthened after a gap of 2 weeks or so. After 2-3 attempts, adequate length is achieved, and then a primary anastomosis can be reconstructed using the lower fistula in situ. This has been achieved successfully, but the total experience still remains quite limited. Another experience is Charlie esophageal lengthening technique, and in this technique there is a division of the lesser curvature of the stomach, but the experience remains limited. Charlie himself reported the outcome of 5 patients, and this was good. However, many other surgeons have also tried this technique but did not find the technique so useful. The major risk remains about the loss of the blood supply, and even the whole of the stomach may become gangrenous if proper technique is not followed. It is also considered unphysiological because the half of the stomach remains inside the thorax and half of the stomach is in the abdomen. Hence, during inspiration, there is a paradoxical breathing, and this is the major physiological objection to the use of this technique for such cases. Next slide. This slide shows the Kimura technique, where the initial cutaneous esophagostomy has been done, and there is a discharge of the saliva, and sham feeding can also be resumed. At the same time, there is a feeding gastrostomy. However, problem comes because of the repeated chest infection, prolonged stay in the ICU, and also there is a repeated need for the visits for repeated surgeries. The experience is limited and long-term results are also not available. The next slide shows the barium study in a patient who has been repaired with Kimura's technique, and this shows a long stricture in the chest, and that required re-anastomosis. Next slide shows the Sarli's technique, and this has been covered in detail. Another good technique is focus technique, which also involves applying tension on both ends of the esophagus. The thoracotomy is done and sutures are applied on both ends of the esophageal ends, and these sutures are tightened in a gradual way till both ends come closer and closer, and after a couple of days or weeks the anastomosis is achieved. This has gained popularity in the recent past, and many surgeons have achieved good results. This allows the esophagus to come closer, and primary anastomosis becomes feasible. However, there are sometimes problems, and the ends of the esophagus, they may cut through. Also, whenever the primary anastomosis is done, this may also show a higher incidence of leak because of the ends that have been applied under tension with sutures. The experience with this technique is also quite limited, and long-term results are not available. Next slide. et al. Published their experience in 2004 with the use of the delayed primary repair. Excuse me, hold on. Sorry for the interruption. So this technique is also quite helpful, but only limited centers. The newborn stays in the ICU for weeks and even months, and during this time both the ends of the esophagus grow and come closer. In the series reported by Dr. Prempuri et al., in 21 newborns, the mean period of stay of the newborn was 80 days, and it varied from 35 days to 270 days. Hence, during this time, an ICU care of the newborn is required with nursing help and either gastrostomy feeding or a TPN. The initial gap was 3.5 centimeter in these patients, and a median preoperative gap was reduced from 3.7 to 1.5 centimeter. The age at the delayed primary anastomosis was 80 days. The hospital stay was 5.5 months, and it varied from 2 months to 14 months. It's a quite long period and may not become possible to keep the newborns for such a long time in a busy neonatal surgical ICU. Next slide shows the results after wait and watch policy from the series reported by Professor Prempuri, and one would note here that there was a prolonged ICU care as long as 270 days. The stricture formation was also very high, that 3/4 of these patients, 76%, developed strictures which required dilatation, and dilatation for as long as 2 years. And all of these required dilatation. Almost 1/4 of these even required resection of the stricture and re-anastomosis. Another important point to note is that 2/3 of these patients, it means 14 out of 21, developed symptomatic gastroesophageal reflux, and 9 of these 14 with reflux required surgery in the form of fundoplication. And all these procedures required repeated visits of the parents and the patient to the hospital. Thus, one would note that with wait and watch policy followed for these patients, not only that patient requires to stay for very, very long time, but also during the post-operative results, 3/4 of the patient develop strictures and requiring dilatation, and almost 1/4 of these require resection and anastomosis. The reflux is also very common, and 2/3 of those with reflux require even surgical intervention. Next slide. A simple but uncommon procedure has been also adopted to achieve length of the lower esophagus in the form of the division of the left gastric artery or the left gastric vessels. This achieves an additional 2.5 centimeter length of the lower segment, and a primary anastomosis becomes feasible. However, because the artery is in the abdomen, so approach has to be either abdominal, or one can try through a thoracoscope from the thoracic cavity. The experience with this procedure is also limited and long-term results are not available, but this is one of the simple procedures that can give additional length of 2.5 centimeter to a surgeon. Next slide. From our experience, we have noted that whenever a diversion has been done in the form of the gastrostomy and esophagostomy for the wide gap TEF cases, that only 28% return for replacement. It means remaining have either died or they are lost to follow-up. In such a situation, it is presumed that parents require, next slide, only a definitive procedure as far as possible right in the newborn period. And this is possible that in difficult cases, stomach is the only option that can be used to replace the esophagus, and it doesn't require any preparation. It is readily available, and approach could be just abdominal and cervical. Even thoracotomy is not needed in case it is presumed that the gap is already too wide. However, thoracotomy, if already performed, can be closed down, and a neck incision has to be made to make the anastomosis in the neck. Next slide. This shows the operative technique that can be used while replacing the esophagus with the gastric pull-up. Only abdominal approach is sufficient enough in a fresh case, fundus being the highest point that is used for anastomosis. A primary anastomosis should be made in the neck, and a good dissection is required so that the stomach goes very easily through the neck, through the hiatus in the neck for the anastomosis with the upper pouch. Ideally, there is no need for thoracotomy, but in case thoracotomy has already been done to attempt the primary anastomosis, then it is closed. A good mobilization is required at the thoracic inlet so that there should not be any ischemia to the venous flow from the neck to the chest. A pyloromyotomy is done in all cases because vagotomy is a procedure that always invariably done when stomach is pulled up. Most of the time in such cases, a mediastinal route is all that is required, and in any case, this is the route that has already been developed while attempting primary anastomosis. Hence, the route is very easy to be created. Next. This slide shows the patient with the pure esophageal atresia, showing the X-ray with a gasless abdomen. The next one shows the newborn ready for gastric pull-up. The third picture shows the incision in the neck and incision in the abdomen. And the last picture shows the mobilized stomach in the abdomen and the upper pouch in the neck ready for anastomosis. Though it may look impossible to bring both the ends together, but we have never found a difficulty in bringing both the ends together and make primary anastomosis where we have tried to do a gastric pull-up in the newborn period. And when we are talking of the newborns, we are talking that this procedure has been done in the first week of life, any day from second day of life to the seventh day. Next. This slide shows the post-operative care required specifically in this patient. As a routine ICU care, these